So I'm going to start with this very melodramatic statement. Alzheimer's disease is a public health crisis. And I truly mean it. I think the government is beginning to realize that. So in the last 10 to 15 years, any grant that goes into the NIH with dementia in it gets a priority score. So the chances of funding are higher. That's bringing more people into the dementia field. It's too bad they're only doing it because of that reason, because those of us who have been in dementia have known for a very long time this is super important. There's an estimated almost 7 million people in the United States living with Alzheimer's or a different form of dementia. It's the 6th leading cause of death among people of all ages, and 1 in 3 seniors will die with some form of dementia. So before I go into the gloom and doom of dementia, I'm going to talk about healthy brain aging. We used to think that it's kind of like if it's in your bad luck, you're going to get dementia and there's nothing you can do about it. We know that that's not true anymore. Okay, so I'll talk about healthy brain aging. First, what is it? This is what we all want as we age. We want to have the ability to think, reason, remember, to carry out our tasks, basically to live your life, to function independently, to remain socially connected with our family and our friends, and to keep our own sense of identity. So this is what we all aspire to as we reach for old age. Now, there are some changes that happen with normal aging in the brain. One is that certain parts of the brain shrink, and this is especially true for the hippocampus. The hippocampus is a very tiny center. It's kind of in the middle of the brain, and it's the memory center. And when they've done studies on older people, they've found, in general, older people's hippocampus is smaller than younger people's. When they've done studies on the same person over time, looking at MRI scans over a period of time, your hippocampus shrinks. All of ours does, a little bit. That's normal. There's also a slight decline in the ability to learn new things and to retrieve information. Have you all had this experience? Sometimes I see some sheepish looks in the room, remembering names sometimes, finding the words. All of us have that. There's difficulty in multitasking. Although many of the scientists say multitasking is a myth, you shouldn't be doing it. You should be doing one thing at a time rather than trying to do 5 things at the same time. But it's not all bad. Some things actually get better. Things like vocabulary, problem solving, judgment, impulse control, things I call wisdom, actually get better with age. So it's not all downhill. There are a few things that get worse, but a few things that get better. Now, some of this looks very similar to what I said is the goals of the mini medical school, right? Physical activity, social activity, mental activity, good nutrition. These have found to also be very, very predictive of healthy brain aging. So this is what we really try and stress to our older patients, is there is a lot you can do. We used to think there isn't, but now we know if you remain physically active, if you remain socially active, you're both physically and socially active by being here. You're being mentally active by watching this. Even those online are, maybe they didn't do the physical and the social part, but they're being mentally active by trying to learn new things. And then good nutrition. As far as the nutrition, the studies have really shown the best data is on the Mediterranean diet or different versions of the Mediterranean diet. They've shown that people who follow that type of dietary pattern through their lifetime have a lower chance of developing dementia in late life. The other thing that's a relatively new concept over the last, again, 10 to 15 years is reducing risk factors for heart disease. There's a huge heart-brain connection. So things that are bad for the heart are also very bad for the brain. So what are those heart disease risk factors? The top 2 are the most important as far as preventing brain disease. Keeping control of high blood pressure and keeping good control of diabetes throughout your life. This is really important. Don't wait until old age to do this. In fact, what we found is most people who develop either diabetes or high blood pressure do so in middle ages. And then they have it for usually decades following that. If you've been for years with uncontrolled high blood pressure and uncontrolled diabetes, and now you try and control them strictly, it could actually have a paradoxical effect in old age. So it's really important that we tell young people, middle-aged people who have these conditions, have good control of these conditions throughout your life. Controlling high blood cholesterol, avoiding obesity, stopping smoking. At any age, stopping smoking can be helpful. Some people say it's too late for me. I've been smoking for 50 years. It is not too late. You can still get benefit from stopping. Staying physically active. And again, having this lifelong pattern of doing so. So now I'll move into what is dementia. And before I tell you what it is, I'll tell you what it's not. So there are some common myths. One is dementia or memory loss is the same as senility. It's an inevitable part of growing old. How many of you believe this? Okay. By saying this, you're saying, if you're old, you will always get dementia. It's inevitable. And we know that that's not true. My mother had her 93rd birthday a few months ago. Her mind is sharper than mine. I don't know what that says about me, but honestly, her body isn't. Her body's giving out slowly. She's getting very frail, but her mind is incredibly sharp. And all of us know people well into their 90s and even beyond who have very sharp minds through their entire life. Okay, so it's not inevitable. Senile means old. If you say old equals dementia, you're doing an injustice to older people everywhere. Okay? The second myth is that nothing can be done for dementia. Now, I will admit we do not have a cure for Alzheimer's disease yet. We don't have one. I'm hoping in my lifetime that we will see that. That's what my entire career has been geared towards, is to hoping that someday this disease will not exist. Despite not having a cure, there is so much that we can do for patients. The other myth is that most people don't want to know if they have dementia. And again, studies have shown that's not true. When they've asked older people, if you did develop dementia, would you want to know? The vast majority say yes, I would want to know so I can plan for it. So all of these misconceptions contribute to the under-recognition of dementia, and I'll show you information on that as well. So what are the facts? It is not normal aging. It actually represents several types of diseases. It's not even a single disease. It's multiple diseases that comprise the whole syndrome of dementia. It's a common condition. It's underdiagnosed. There are many people in the community who have no idea that they or maybe their loved ones have dementia. It's a very, very expensive disease. And it's a fatal disease. You can actually die because you have dementia. The other fact is that people who have this condition should have a thorough evaluation by someone who's expert in the condition. So what are the definitions? First of all, it's acquired deficits. This means somebody who has congenital intellectual problems, somebody who was born with some form of mental retardation, say, that doesn't count. This is somebody who was doing fine, was intellectually normal, and now has a decline. There's a change in the condition. You need to see a deficit in memory, but not only memory. At least one other cognitive domain needs to be affected. I will talk about some of those domains on the next slide. It needs to be bad enough that it's affecting your life. It's affecting your social functioning with your family and friends. Or if you're still working, it's affecting your job performance. It's actually affecting your life. And you have to have an absence of delirium or other major psychiatric conditions. Delirium is an acute confusional state that we actually see mostly in the hospital. I think I'm going to have that as a topic for next year's series because a lot of people have been asking me questions about that. So the hospital is not a good place to make a diagnosis of dementia because often older people who are in the hospital are acutely confused. It's a sudden change. That's delirium. We have to wait until the delirium clears to see if the patient still has dementia. If somebody is in the throes of a major depression, again, that's not a good time to assess because it could be the depression that's causing some of these symptoms, okay? There's this condition called MCI, or mild cognitive impairment. This is sort of like a pre-dementia syndrome. People have a subjective complaint about their memory. It can be from the patient, but it may not be from the patient. It may be from a family member, a proxy informant. A family member or friend may notice that somebody's having a memory problem. They have to have cognitive deficits on testing in at least one domain. It could be memory, it could be language or attention, or executive function, which is the things that we do with the frontal part of our brain, things that we do for planning and higher functions, or visuospatial abilities. Could be any one of these are affected, and on testing you find some deficits. But they're functioning fine. If they weren't functioning fine, they would have dementia, right? So these are people who may have a complaint, and on testing they have problems, but they're still able to function. They're able to take care of themselves, they're able to interact with family and friends, they're able to even work, but they're still having some deficits. So why do we care about this condition? There's a high risk of converting to Alzheimer's disease. People who have MCI, in 5 years, about half of them will have a diagnosis of Alzheimer's. Why do one half convert and the other half not? That's an excellent question that nobody knows the answer to. That's a really hot area of research. If we could keep everybody at this MCI stage and avoid that progression to dementia, that would take care of a lot of misery and cost and basically health issues in the world. So why do some convert and some not? We don't know. We're really studying that very much, because that's the goal, is to keep people from either staying at MCI or maybe reversing it completely and not moving on to having dementia. Unfortunately, it is very common. If you look at people over the age of 65, the studies vary a little bit in numbers, but it's about 13% have dementia. If you look at those over 85, it's almost half. So it's certainly an age-related disease, although it's not just age that causes it. We see a geometric increase in the prevalence of disease. So I'm going to show you this next slide. Oh, that didn't... I don't know what happened to that slide. Okay, what it's supposed to show... Philip, my mic, can you help? That's not how it looked on my slides. Okay. Oh, can you see it on yours? Okay, so on your handouts, you can see it. So on the horizontal axis, it's basically age groups, and on the vertical axis, it's the percent who have dementia. The blue bar represents dementia, and the red bar represents those with either dementia or MCI, mild cognitive impairment. And as you can see, it's not a straight line across the ages. It's a curved line. It goes up very dramatically. After the age of 60, the prevalence doubles every 5 years. So when you look at that over 85 group, the last group, that group has a very high rate. If you include the MCIs, it's almost half. If you don't include MCIs, it's about a third. So very high rates of dementia. Next, I'll go on to the subtypes of dementia. So this slide is incredibly important. I think this is something where people get really confused. I've had people come and say, my doctor says my husband does not have dementia, but he has Alzheimer's. That doesn't make sense because Alzheimer's is one of the types of dementia. Dementia is the umbrella diagnosis. All of the subtypes fall under it, okay? So Alzheimer's is by far the most common subtype. It's seen in about 60 to 80% of dementia. So about, I would say, 2/3 to 3/4 are going to be Alzheimer's disease. But then there are many other causes as well. This makes it a little clearer. This pie chart shows Alzheimer's disease is about, again, the most common, especially in white populations. Vascular dementia, which is related to strokes, is in the red, and that is about 10 to 20% of dementias, again, depending on which study you look at. Then we have Parkinson's disease and the Parkinsonian syndromes that can cause a dementia, and then we have a whole bunch of other mixed types of dementias. Some of these dementias are actually reversible. None of the ones I've listed on this list, but there are some causes of dementia that can be reversed, and this is why I'm such an advocate for finding dementia as early as possible, just in case we find those rare reversible causes. So this past slide was in white populations. We know that there are some differences in Asian populations, so I'm going to show you some information from our own studies here in Hawaii. I've been honored to be part of the Kokini Honolulu Heart Program and Honolulu Asia Aging Study since I first moved to Hawaii. This study first started in 1965 at the Kokini Medical Center. This year, by the way, is the 60th anniversary. The 60th anniversary is going to be next month. It's the third longest running research study in the United States. And of the 8,006 men who originally participated, 2 are still alive. Both are 105 years of age. We have also done many studies in their offspring. So we call them the children of the Honolulu. They're not children, they're in their 80s, some of them, but they were children of the original Honolulu Heart Program. And this study has provided a lot of the information that has been used worldwide for heart disease, stroke, cancer, and now dementia as well. So it first started, the Honolulu Asia, it started as a study of heart disease and stroke in 1965 in Japanese American men. In 1991, the focus shifted to aging. The men were now 71 to 93 years of age. So we were looking at cognitive function, dementia, disability, depression, many of the conditions that are more common with aging. And this is what we found. Again, if you look at the horizontal axis here, these are the age groups. The one on the left is 71 to 74, and the one on the rightmost is 85 to 93. And if you look at that curve, it looks very similar to the national statistics I showed you before, right? It's low in the younger age groups. There's a very geometric increase until the older age groups. And in that oldest age group over 85, it's about 1/3 who have dementia, and then if you include the MCI, it's almost half. So what we found is our Japanese American men in Hawaii had very similar rates of dementia as people on the mainland and people all around the world in white populations. But this is what we found that was different. When we looked at dementia subtypes, again, we've got the same age groups. Now in blue, I have the Alzheimer's disease component, and in red, I have the vascular disease component, the stroke component. If you look at that youngest age group, the stroke component was actually more common than Alzheimer's. Now, after that, Alzheimer's overtakes and becomes number 1. But the ratio isn't the same as in white populations. If you remember that pie chart, a huge chunk of that pie was Alzheimer's disease and a very small wedge was vascular. We are not quite like that. And this is very similar to studies that have been done in Japan, China, Korea, where strokes are an important contributor to dementia in Asian populations. In some of those countries, actually, stroke-related dementia is number 1. We found Alzheimer's was still number 1, but stroke was definitely more common. The other thing we found is in white populations, the type of stroke that causes dementia is large strokes in the cortex, or the main parts of the brain. And you see the stepwise decline. They have a stroke, they drop, they plateau, they drop again, they plateau. You see steps. In our Japanese men, we found many of them did not have that stepwise decline. Many of these strokes were asymptomatic strokes. The patient had no idea they had a stroke. They had a very gradual decline that's very similar to Alzheimer's, but when we did scans, we found they had 3 old strokes that they had no idea about. So you can see how different ethnic groups might present in very different ways with the same disease. I'll move on to Alzheimer's disease. This was first described by Dr. Alzheimer in 1906. The case that he had, the lady that he had who had dementia, was in her early 50s. It was really tragic. She had a very rapidly progressing dementia syndrome. She died under his care. He did an autopsy on her and he got her brain, and he actually showed the abnormal proteins in the brain that to this day are the hallmark of Alzheimer's disease. So this disease was known over 120, almost 120 years ago. Yet there was very little research done in this disease until about the 1980s. The main reason for this is even though this first patient of his was young, that's why he called it a pre-senile dementia. She was a young lady, middle-aged lady, I guess. In general, most people who have Alzheimer's disease are older. If you think about life expectancy in 1900, I think it was about 40 to 45 years. It's almost doubled in the last century. So in the early 1900s, they thought this is a very rare disease. As people started living to older and older ages, it became a common disease. And that's why suddenly it's become a huge area of focus as the population ages. Short-term memory, orientation, and problem solving are affected very early in this disease. Behavior problems, unfortunately, are very common and can be actually very distressing to the patients and to their families. It has a very insidious onset and a very, very slow progression. When we ask families about it, you get totally different answers. We ask, when did this begin? One person will say, I noticed a year ago. Another one will say, no, I noticed from 5 years ago. Because it's creeping up on you. It's not something that happens suddenly. But it is relentlessly progressive. The duration of disease is also variable. Some people have it over a short period of time and then die quickly. The duration can vary from 2 years from diagnosis to death to up to 25 or even more years. I've known people who've lived for decades with this disease, a very, very slow progression. The average is about 8 to 10 years from diagnosis to death. This is Dr. Alzheimer, and this is his patient, the first patient who was diagnosed with this disease. So this is what Dr. Alzheimer found and what we've known ever since. First of all, there's a deficiency in chemicals in the brain, and particularly acetylcholine. Acetylcholine is the memory chemical. And we find that patients with Alzheimer's have lower level of this chemical in the brain. So this is, let me see, yeah, this one here. This one shows these are the brain cells and the synapses, the connections between the brain cells. These chemicals are the messengers that give messages between the brain cells. There's also 2 abnormal proteins. These are what we call beta amyloid plaques, and these are called neurofibrillary tangles, which is basically a hyperphosphorylated tau protein. Both of these abnormal proteins are laid down in the brain. And what they're doing is they're killing the brain cells. Neurons are brain cells. Brain cells are dying in Alzheimer's disease. They're being strangled by these abnormal proteins. So if you look at this brain up here, this is a normal brain at autopsy. This is an Alzheimer brain at autopsy. You don't need a microscope to see the difference. The Alzheimer brain is shrunk. That brain has lost a lot of brain cells. Okay, that's what happens in this disease. I'll go into risk factors, and I've divided them into 2. One is non-modifiable, and then the other one is modifiable. So for non-modifiable, the top one is age. We have still not found a cure for aging. We are all getting older every single day. And age is one of the strongest risk factors. The second one, which is almost as important, is actually low education. That's been found to be consistent. So higher age and lower education in every country, in every ethnic group, in men, in women, has been found to be a risk factor for Alzheimer's disease. It's very, very consistent. Traumatic brain injury is a little bit more controversial. Some studies have found a connection, others have not. I will say I would not recommend getting your head repeatedly pummeled. Everybody's laughing, but there are some sports where that is the exact point, to knock the other person out, to give them a concussion. That is the point of that sport. My husband watches things sometimes. I'm like, don't watch that. It's horrible. It has been getting a lot of attention in the last few years because of the National Football League, because they have these young, healthy men who are testing like they have Alzheimer's disease in very young age because they've had repeated concussions. So it's not a good idea to have your brain repeatedly hit. I have a slide on genetics. I'm going to get to that next. The modifiable ones, we've talked about some already. Heart disease risk factors, particularly high blood pressure and diabetes, having good control throughout your life. Don't wait until old age. Dietary factors. Heavy alcohol intake is not good for the brain either. Depression. Depression is very interesting. I don't think it's actually a cause. I think depression is one of the early symptoms. It's actually one of the early markers. And what they've found is if you treat depression, sometimes those symptoms will get better. So let's say I have an older person who comes in with memory complaints, and I make a diagnosis of major depression. Of course, I will treat the depression. And actually, they get better. They feel better, their mood is better, their memory is better. But many of these patients, it's an early marker, and you have to watch carefully because down the road, they may be developing Alzheimer's disease. Chronic inflammation is a risk factor. Sleep apnea and any kind of sleep disorders can be a risk factor. More recently, hearing impairment has been found to be a risk factor. And they found, so we knew hearing does contribute to cognitive decline. What we didn't know is, does fixing the hearing help? And some studies have found, yes, it does. So I really recommend people who have hearing impairment go get tested for hearing aids and get those, because it may help you in many different ways, including your quality of life. Let's move on to genetics. Everybody has this question in their mind, right? My father died of Alzheimer's disease. I have this question in my mind too. We all do. Well, let me give you a little bit of reassurance. So there are two types of Alzheimer's that have been noted. One is the late onset, which is the more common one. That's vast majority of Alzheimer's disease we see is the late onset Alzheimer's. Then there's the early onset. These are very dramatic. These are people who get Alzheimer's in their 30s, 40s, 50s. Many of the movies that are made about dementia have this type of patient. It's kind of giving the impression that this is the common type. It is really not, but it makes for a better movie, I guess, if you have somebody in their 30s or 40s having Alzheimer's disease. So the press kind of focuses on these a lot, but these are actually quite rare. There have been 3 genes that have been found to be linked to Alzheimer's disease. They are autosomal dominant genes. What does that mean? If you have the gene, 100% you will get Alzheimer's disease. It's an autosomal dominant gene. If you live long enough, you're going to get the disease. For these people, I do recommend genetic testing if they ask for it. And actually, I recommend genetic testing and counseling for the whole family. Okay, because it is an autosomal dominant. There are other autosomal dominant genes out there we don't know about. They haven't been found yet. But again, this is a rare condition, so we don't see this very often. We know Down syndrome has some connection to Alzheimer's disease. We're not sure exactly why. When children with Downs grow to adulthood, let's say we have people with Downs in their 40s and they die of some other reason. They don't have a clinical dementia, but they die in their 40s. When autopsies have been done on their brain, 100% of them by their 40s have plaques and tangles in their brain that are similar to Alzheimer's disease. They may not present with the dementia syndrome, but they have the lesions. So there's clearly some kind of connection, and again, a lot of research being focused on this as well. What about majority of dementia? The majority of Alzheimer's disease is the late onset or sporadic Alzheimer's. Family history may be a slight risk factor for this one, but part of it is also family history of longevity. If you have a family where you have many people living into extreme old age, like our Honolulu Heart Program men, where I think when we looked at people living to the age of 90, 1/4 of those men lived to the age of 90 and above. It was a very long-lived cohort. If you have lots of people in your family living to extreme old age, and age is one of the stronger risk factors for Alzheimer's disease, you're going to have Alzheimer's in your family just by virtue of having a lot of people living to extreme old age. So there's a slight increase, but it's not a guarantee. Apolipoprotein E4 is a gene that has been found to be a risk factor, but we don't test for it routinely. It increases the chance of having Alzheimer's, but you may have the gene and never get Alzheimer's. You may not have the gene and get Alzheimer's. So I don't recommend testing for this routinely. At the very end of this talk, when I talk about the newest medications that have come out, for those patients, I do recommend testing for ApoE4, but not for the general public and not for every patient who has Alzheimer's disease. So what about those protective factors? These are data, again, from the Kukini Honolulu Heart Program. This was walking, just simple walking. Because I have a lot of older people who tell me, I have bad knees or a bad hip or whatever. I can't run. I can't jog anymore. I can't do vigorous exercise. This was just simple walking. We asked the men how much they walked, and we divided them into 4 groups. So that's on this axis over here. This was the highest walking group. They walked over 2 miles a day. This was the lowest walking group, who walked less than a 1/4 mile a day. And then we followed them for the next 8 years to see who developed a new dementia. And you can see the people who walked the most had the lowest rates, and it went up and up and up until the lowest walking group was almost double the risk. So just simple walking can be really, really good for not only your heart, your bones, your muscles, but also your brain. What about the social engagement? Again, we did the same thing. We looked for new dementia, and we divided them into high social engagement, it's on the right, to the lowest social engagement on the left. And again, a very significant trend. People who remain socially engaged in old age, their risk of developing a new dementia is less. It's almost half, more than half in this case, of those who socialize very little. So again, good reason to get out of bed and come here and go to senior centers and go to places, right? Lots of many good reasons to do that. Next, I'll tell you why early detection is so important in my mind. One is, of course, those reversible causes. They're not very common, I will admit to that. But if you have it, wouldn't you want to be the one who has it reversed quickly rather than suffer for years and maybe have it become irreversible? Even more important than that, I think, is improving treatment of underlying conditions. So for example, let's say you have high blood pressure and asthma. You go to your doctor. The doctor is giving you all these instructions about medications, about exercise, about diet. The patient is smiling and nodding politely, but they're not remembering anything. If the person has dementia, how do you expect them to follow the instructions? They didn't even remember them. So it's very important to have the caregiver in the room with them. To reduce ineffective and expensive crisis care, these are the patients who miss appointments, who show up at the ER, who get hospitalized over and over again because of various medical conditions. Patient and family education, advanced healthcare planning, planning for the end of your life, whenever that might be, financial planning. I have a whole slide on safety issues that I'll show you, and connecting to available community services as well. So again, these are our Kokini Honolulu Asia Aging Study participants, and we asked the caregiver, does Mr. X have a problem with his memory or thinking? And this left bar is they had no problem. The middle one, they actually had MCI, or mild cognitive impairment. These people met research criteria for dementia. And if you look at no memory problems, 20% of the caregivers said no memory problems. You don't notice it if you live with the person. It's creeping up on you, right? Day to day to day. This was even more alarming. The same 3 groups, we asked, did they have an evaluation for memory problems? Again, focus on the red. Among those with dementia, less than 40% were evaluated. Among those with MCI, less than 5%. We are missing this. Physicians are missing this. One of my previous fellows, who's now at UCSF as a professor there, did this study when he was a fellow, looking at primary care practice, and he looked at undiagnosed dementia, and this is what he found. Among all the older patients, 2/3 of dementia was missed. Among mild, 90% were missed. Moderate, 50% were missed. Okay, none of the severe dementias were missed. Should we be proud of that? I mean, a child could diagnose a severe dementia, right? It's not something to be proud of. If you don't look, you won't find. Okay. So let's go on then to symptoms of dementia. Memory loss, initially short-term, but later even long-term memory. Disorientation, to the date, also to the place. Difficulty with naming and understanding can be symptoms. Many patients with Alzheimer's in particular have a lack of insight. If you ask them, how's your memory? The most common answer is, my memory is great, because they don't even realize they have a problem. Behavior, personality changes, wandering can be a huge issue and can be very dangerous. And these patients can be socially inappropriate and have very poor judgment. I won't go over this, but this kind of goes over the different functions of different parts of the brain. The memory center is here in the temporal lobe. It's kind of between the temporal and the parietal lobe. The hippocampus, it's very deep inside. That's why it doesn't show on this slide. For dementia, we have to look at a lot of things. The ABCs, functioning, activities of daily living. Are people able to take care of themselves? Behavior problems. How is the cognitive function changing over time? Never forget the caregivers. May I see hands? How many of you have been caregivers before? See a lot of hands raised. Give you all a lot of credit. It's the most difficult job in the world. Sometimes the most unappreciated job in the world too. Disease progression is inevitable, and education at every visit, I think, is really important. So let me move on then to treatment. There are 3 stages of Alzheimer's. So there is the pre-symptomatic stage, there's the MCI stage, and then there's a dementia stage. These lines are artificial. It's not like one day you're normal, one day you're MCI, or one day you're MCI, one day you're dementia. It doesn't work like that. It's a very gradual progression. But what we see is in this early stage, both function, which is the purple line, and cognitive performance are more or less normal. Once you get here into the MCI stage, your functioning is still okay, but now your testing is not doing well. Your cognition is not doing well. Once you're dementia, both of them get worse and worse. So we want to prevent this for the whole population, recognize people at high risk early, and then try and find those reversible causes if we can, and try and treat those as soon as we can. These are the FDA-approved treatments for Alzheimer's disease. There are 2 classes that have been around for a very long time. One is the cholinesterase inhibitors. What they do is try and restore that memory chemical acetylcholine to the brain. And there's several of them, and they're all about the same efficacy. There's the NMDA receptor antagonist. It attacks another receptor in the brain called memantine or namenda. At best, all of these drugs cause temporary stabilization. they really don't do much, and the progression continues despite being on these medications. Some of them might help behavior, which can be a real blessing, so sometimes we put patients on these for behavior management. All of those meds, all they're doing is tackling the chemical deficiency. None of them are tackling these, the plaques and the tangles in the brain, which is killing the brain cells. Okay, so the new FDA-approved treatment, there are 2 of them now. They actually treat this beta amyloid antibody. So it's a beta amyloid antibody that tries to clean the brain of these abnormal proteins, of at least the amyloid protein that's laid down. The first one, Aduhelm, is now off market. The second one, lecanemab or Leqembi, it got full FDA approval about 2 years ago. It's only been found to have an effect in very early Alzheimer's disease. The original study was about 18 months long, so if you ask me, what does it do 5 years or 10 years down the road, nobody really knows, because these are relatively new drugs. They're not pills. You have to go in for an IV. So you have to go in for lecanemab, an IV infusion every 2 weeks. The cost of just the drug is $26,500 per year. That doesn't count the infusion costs, the scan costs, all of those other costs that come with it. So I recently found out it's closer to $85,000 to $95,000 a year of total costs. So you have to really check whether your insurance covers it. The diagnosis for this, to be eligible for these medications, you have to have an amyloid PET scan. We do not have an amyloid PET scanner yet in the state of Hawaii. Queens is working really hard to get one. I'm told it's coming before the end of the year, but I don't know exactly when. So for now, if you want an amyloid PET, you have to fly to the mainland to get it. Or a lumbar puncture, that's a spinal tap. So spinal taps are not as bad as they're made out to be. On the other hand, none of us wants to really volunteer for one if we don't have to, right? So I hope that amyloid PET comes. There are some side effects of this drug. It's not all great. The side effects are what we call ARIA, amyloid-related imaging abnormalities, which is brain edema or swelling or brain bleeding. Most of the time, these are mild and even can be asymptomatic. But what it means is you have to monitor these patients. They have to get repeated MRI scans. And if they are starting to show those signs, we have to stop the medication. Some of them, actually, we have seen some severe ARIA as well. So this was the original study for lecanemab. And if you look at this was 18 months. This was change from baseline in lecanemab versus placebo. The placebo gets worse quicker. But lecanemab is also still going down. It's not a cure. It's not like it stopped the disease. There was a 27% reduction in the decline. This slide is really interesting. So if you look at this box B, this is amyloid in the PET scan. And look at this, the placebo, it cleans the brain of amyloid. This drug cleans the brain of amyloid, okay? So if you look at the placebo stays the same. This drug, the amyloid burden has gone down. This drug is working to clean the brain of amyloid. But these are all the cognitive and functional scores. Both groups are still going down. So that's why we're asking, why is this brain completely clean of amyloid and still not? Why aren't these graphs looking the same as this one? If it did, I would be super thrilled. It's not. So there's still a lot of work to be done. Remember, there are other abnormal proteins, not just amyloid protein. So there are other clinical trials happening for those as well. Okay, so for safety issues, medications, patients with dementia need supervision for their medications. They might take too much, they might take too little. Over-the-counter medications can be dangerous for some patients with Alzheimer's. You have to be very careful about those. For wandering, getting a medical alert bracelet is important. The Silver Alert Bill was passed in Hawaii. So now, just like an Amber Alert, if an older person with dementia goes missing, the search starts immediately. You don't have to wait. Leaving the stove on can be a fire hazard. Leaving the water running. Driving, huge issue. These patients can be at risk for elder abuse and neglect as well as financial abuse. So for summary, early diagnosis is key. Treat the cause, treat the complications, provide a safe and stable environment, give caregivers support, educate the family with a team. Community resources. AA, by the way, in geriatrics is never Alcoholics Anonymous. It's always Alzheimer's Association, just to let you know. And the Executive Office of Aging of the Department of Health. And then providing planning. So what are our goals? Really, our goals are patient-dependent. We want to find out what matters most to that patient. In general, I would say it's not necessarily keeping people alive longer and longer. It's more giving them good quality of life, maintaining functioning for as long as possible, avoiding that social isolation. I've had people ask me, Mom won't remember tomorrow. Should we take her to the family picnic? My question is, does she enjoy it while she's there? If she does, please take her. Give her a good day. Give her many good days. She may not remember tomorrow, but give her as many good days as you can, okay? And then care for the caregiver. I'll end with a plug for the Alzheimer's Association. They're partners of ours. We work with them all the time. We do education together. We do research together. We do lots of things together. I think now they're located in the Gold Bond building, which is right across the way. They have wonderful resources. They have a wonderful website. They have caregiver support groups, all kinds of things. So please do call them if you have questions, okay? And I'll stop here. And Chang won't be angry because I didn't go too far over time. Thank you. Do you have any questions? Yeah. Gary?
Hi. Thank you very much for the excellent presentation. Question, early on in your talk, you mentioned or hinted at a paradoxical effect of treating hypertension in as one ages. Can you comment more about that?
Yeah. So let's say you've had high blood pressure for 30 years. You started when you were 50, you're now 80. Okay. If you've had good control of your blood pressure for that entire time, then it's actually been good for your brain as well. So your chance of having stroke, of having even Alzheimer's disease. So when our study, our Honolulu Asia Aging study, we found that that high blood pressure was linked to old age cognitive problems. Everybody said, big deal. We know high blood pressure is a risk factor for stroke. Stroke causes some forms of dementia. This is all stroke related. We actually had an autopsy study. So we have almost 1,000 brains. And we found that not only did they have higher rates of stroke, but those with untreated hypertension had more plaques and tangles in their brain. So even the Alzheimer lesions were higher if you didn't have good treatment of your high blood pressure. If your brain has gotten used to having a high blood pressure for the last 30 years, because it hasn't been well treated, and now you suddenly drop the blood pressure, it actually could have a paradoxical effect in that the brain is now not getting perfused enough, can actually cause you to be more confused and even fall and have other issues. So when we treat blood pressure in older ages, we are a little cautious. We don't aim for as low as we would in a younger or middle-aged person, and we do it a little bit more slowly for those reasons. Same with diabetes. We wouldn't want to, people with dementia will have trouble recognizing hypoglycemia. Hypoglycemia is low blood sugar. Diabetics who are on treatment have a risk of having low blood sugar. You are taught how to recognize those symptoms, to carry something with you to take, to suck on a candy or take sugar or something when you have low sugar, which can be very dangerous. Older patients with dementia don't recognize those symptoms. So I'd rather keep their sugar a little high than risk that sudden dip in hypoglycemia. It's more dangerous, okay? Yes. Oh, we've got mics going around, so I'm not sure where the mic is. Chang, are you monitoring the chat too?
I am.
Okay.
Thanks so much, Dr. Masaki. Again, excellent presentation. You made a really difficult topic very understandable, I think, for most of us. My question is kind of twofold. One, you don't mention smoking as a risk factor?
Oh, it is.
Yeah, but
Oh,
it
it
wasn't
is,
on
yeah.
your list, and I was just
Oh,
surprised.
it is actually on the list, but it's not quite as high as high blood pressure and diabetes tend to be the strongest.
Right.
But all the cardiovascular
You-
risk factors,
okay,
smoking,
okay.
obesity, all of those are risk factors.
And
yes.
I'm wondering what your take on the new American Heart Association guidelines for lowering blood pressure target.
Yeah.
Yikes.
Yeah,
Okay.
this is the most controversial area in the field of geriatrics right now, is how low to go for your blood pressure. In fact, at the American Geriatric Society, we usually have a plenary session on this because everybody's got different opinions on it. There has been a recent study come out, the SPRINT trial, that actually showed even in very old age, even in frail people, you can successfully lower blood pressure to quite low and they do okay. I worry about that, particularly in, so if, again, if it's not just the number, age is not just a number, it's the person, right? So if I have a very frail older person who's falling and who has other things happening to them and who gets lightheaded when I'm putting them on higher doses of blood pressure medications, I feel like I want to keep that blood pressure a little bit higher. So again, you will find other doctors who will disagree with me on this. And I can't say that they're completely wrong and I'm completely right. I would say from the geriatricians that I know, about 80% are the same as me, kind of like, let's do no harm. But there are some who believe in the more aggressive treatment. So, yeah. It's a very, very controversial area, though. Yeah. Any other-
Excuse me.
Yes, yes.
Yeah, my question is with regards to coffee intake,
Coffee, yeah.
because there's been back and
Yeah.
forth on whether it is beneficial or not. So
Yeah.
could you comment on that, doctor?
Yeah. Coffee has been found to be very beneficial for Parkinson's disease, actually. So people who are coffee drinkers definitely have, this has been shown consistently. Our study was one that showed that, but many studies have shown that it seems to, there are nicotinic receptors in the brain that are affected, and that's thought to be the mechanism. So it definitely is linked to lower risk of Parkinson's disease. With dementia, the reports have been mixed. So it's not been quite as strong, either risk or protective, as it has for Parkinson's, where it's clearly protective. Yeah. I see some hands on this side. Yeah. Okay. Sorry.
Dr. Masaki?
Yes.
I just want to thank you for mentioning that about the high blood pressure.
Yeah.
I kind of went after my husband's heart surgeon because he didn't want to recommend him change his diet. And it makes good sense. And so he keeps his blood pressure. He checks it every day. And now that I understand, you're saying that if it goes down too low, that could be dangerous. And I thank you very much for
Sure.
mentioning that.
Again, check with your doctor. So diet, I talk about nutritionally balanced and, having a really healthy diet. I will tell you, though, I have had some patients who their baseline weight was 80 or 90 pounds. They were just small women who've been that their entire life. And they start losing weight. That's dangerous in old age. And the first thing I do is liberalize their diet and say, eat anything you want. If you want to eat your cookie for lunch, fine, do it, because weight loss can be dangerous too. So again, I know that sounds like I'm being hypocritical, but honestly, it depends on the patient and everything that's happening with them. Yeah. I've never been in that stage where somebody has told me, eat anything you like. So, Chang has a question.
We have an online question. Have you heard about the CMS's guide program at Straub?
Oh, yes. Thank you for bringing that up. So Medicare, CMS is the Centers for Medicare and Medicaid, the federal government. And they put out this call for what they call the guide program for dementia care. And Straub applied for it and got it. So they are enrolling patients. So my colleagues, my geriatrician colleagues there are part of that. And they're enrolling patients in the guide program. They provide some specific services, including not huge amounts, but limited amounts for respite care. So if you're interested, certainly do call Straub and ask. Dr. Susan Price is a geriatrician there at Straub who's sort of overseeing that program. I don't know if she's the only one, but she's the main one overseeing it. Yeah. I see, yeah. Yes.
I'm wondering if you could share a little bit more about sleep apnea and
Yeah.
how sleep apnea is a contributing factor.
Yeah, sleep apnea actually can be more dangerous than people think. You know, they think it's only affecting your sleep, but it really affects your entire body. So what happens with sleep apnea is while you're sleeping, it depends on the type of sleep apnea, but basically your oxygenation is dropping sporadically during the night. The most common one is the obstructive sleep apnea, where your airway is closing. So the bed partner will say, the patient themselves will say, I don't snore, I don't do anything. The bed partner will say, oh yeah, they snore. Or you can hear them wake, kind of gasping for breath in the middle of the night. That's what happens, is you're having these micro times of stopping breathing and your oxygenation drops. So that can have many effects on your entire cardiovascular system, on heart disease, on stroke, and even on your brain, on memory. There are treatments for that, by the way. So weight loss is one of them. Obesity is one of the big risk factors for sleep apnea. So weight loss is one of them, but there are other treatments as well for many people. Yeah. Oh, Chang has an online.
No, go ahead.
Oh, okay.
Could you please elaborate on early detection?
Oh, yeah.
And you were saying that possibly some reversal.
Yeah.
So is there any advantage to be tested as a preventative, or should we wait for symptoms?
Yeah. Again, this is a controversial area. As a geriatrician, I think everybody should be screened. And that's why we're actually trying to train primary care doctors' offices, because there are not enough geriatricians or neurologists around to do this. So we're actually trying to train primary care doctors to say there's some very simple screens that take like 2 or 3 minutes. They can train their nurses or medical assistants to do the screen, and only if the screen is positive, they need to do something and then refer out. So we are recommending to them that they do that they screen everybody over the age of 65 at least once a year. The Medicare annual wellness visit, if your doctor is doing that for you, some doctors are doing it, some are not, but Medicare pays for an annual wellness visit for everybody who's on Medicare. That actually includes a cognitive screen, so I'm thrilled about that. I believe that everybody should be screened. What are the reversible causes? Having too low levels of thyroid gland hormones in your blood sometimes can be reversible. Certain vitamin deficiencies can be reversible. These can be tested for. The most common, the most reversible one is what we call normal pressure hydrocephalus, where there's a little blockage in the brain of drainage of the cerebrospinal fluid. And so the ventricles that are in the middle of the brain are kind of swollen and are pushing on the brain matter. A very, very simple surgery, not by people like me, but by neurosurgeons, for them it's very simple, can fix that, just shunting that fluid away. I've seen people miraculously get completely better. So those are not common. None of those things are common. But if you're the one who has that, wouldn't you want it found early? Normal pressure hydrocephalus, I've seen patients who've had it for by the time they came to me, I've sent them to the neurosurgeon says, too late. Surgery's not going to help. That's a tragedy to me. So that's why I feel like early detection, workup is really important. Yeah. Do we have time for a couple more, Chang?
Yeah.
Okay.
I read that the use of antihistamines affects the chemical acetylcholine.
Yeah.
If you were a longtime user of antihistamines because of allergies since your teens, does this also have an effect on your brain?
Yeah, that's a really good question. So I talked about acetylcholine, right, the memory chemical. Something that basically suppresses acetylcholine are the anticholinergics. The most common one that I can name is Benadryl. Have you all heard about Benadryl? Everybody's used Benadryl at some point or the other, right? It's over the counter for itching, for allergies, for something or the other. Especially in patients who already have Alzheimer's disease, I do not recommend them taking that. Benadryl makes most people sleepy. in a person with Alzheimer's whose levels of acetylcholine are already low, now you're lowering it even more, it can make them crazy and cause major behavioral problems. So that's why cough and cold medications, many of these things are hidden. Tylenol PM, NyQuil PM, you look inside, that's Benadryl that they put in there to make you sleepy at night. The PM meds, all the PM meds have that. So yeah, be very careful. Long term, I would definitely talk to your doctor, about alternatives. They have shown that, studies have shown that people who are on anticholinergic medications for a very long time may have higher risk of cognitive decline in old age. Some of the newer allergy medicines are less anticholinergic than others, so I would really check with your doctor on this. Okay. Yes.
I often see TV ads for, I think it's Prevagen.
Prevagen, yeah.
What is your opinion, please?
Yeah, I've heard of many of those. So Prevagen is one, ginkgo biloba is another. There are many out there. None of them have been proven to be effective. So the FDA kind of controls the quality of drugs that we take. All of these, what we call nutraceuticals or herbal medications, they're not FDA approved. So some of them have things in them that, so some of them, I've seen studies where they say this contains X milligrams of whatever. When they test it, they find it actually doesn't. They're unregulated. So I don't recommend those because I do think they're unregulated, and many of these herbal meds can have side effects and can have interactions with other medications you might be taking. NIH has realized now people are taking nutraceuticals whether we like it or not, whether we know it or not. Tell your doctor if you're taking anything, by the way. At least tell them, because it's good that they know what you're on in case there are drug interactions. So NIH has created an institute called the National Institute of Alternative Medicine, I think, which is doing testing on some of these kinds of drugs to see. Some of them may pan out to be good, but until they're tested and it's proven, I don't recommend them. Yeah. Do we have time for done? Okay. Sorry, everyone, we're out of time, but it's really been a pleasure. Let me